Hello everyone. Today we'll be discussing two interesting cases of Cauda equina neuroendocrine tumor, previously known as the paraganggliomas. Both the cases are male patients and they presented with low backache and sciatica. Now the case 1 is L1 L2 intradural extramedullary tumor. The MRI of this patient revealed a lobulated septated hyperintense lesion measuring about 43 into 21 into 18 mm in the thecal sac extending from the upper border of L1 to mid L2 level on T2 weighted images. It is iso to hyperintense on T1 weighted images and shows blood fluid levels within. Moderate heterogeneous enhancement on the contrast with non-enhancing necrotic or cystic areas within. No extension into the neural foramina was noted. MRI of the second patient revealed a well-defined homogeneously enhancing intradural lesion measuring about 48 into 14 into 18 mm at L1 L2 level, just below the level of the conus. Multiple flow voids are seen adjacent to the lesion and it appeared hyperintense on T2 weighted images. There is mild extension of the lesion along the L2, L3 neural foramina on the left side. We received both the cases from Dr. Datta Prasanna Katikar, neurosurgeon, Vinith Hospital, Solapur, for second opinion and immunohistochemistry. And surprisingly, they arrived in the same week. Histopathology revealed a well-differentiated, encapsulated, richly vascular tumor composed of neoplastic cells arranged in the organoid or the Zell-Bellin pattern. Now, this is hallmark of the paraganglioma or the Cauda equina neuroendocrine tumor. The neoplastic cells are arranged in nests or lobules, and these are the chief or the type 1 cells surrounded by inconspicuous single layer of spindle-shaped sustentacular or the type B cells. The chief cells are uniform, round to polyhedral. The nuclei are round to oval, uniform with finely stippled chromatin, giving rise to salt pepper appearance. And the nucleoli is inconspicuous. Cytoplasm appears finely granular or maybe clear. Mild degenerative nuclear pleomorphism may be present but has no prognostic significance. The sustentacular cells are spindle-shaped cells and many a times they are not appreciated on the light microscopy, and these are S100 immunopositive. Mitotic activity is minimal, but sometimes it may range from 0 to 5 per 10 Hypar fields. Mature ganglion cells or Schwann cells may be noted, and at a times ependymoma like perivascular arrangement of neoplastic cells may be found, so the ependymoma needs to be ruled out on IHC. So this is a mild degenerative nuclear RTPI is noted, and we can appreciate the fine delicate vasculature separating the neoplastic cells. This is the typical finely stippled chromatin giving rise to salt pepper appearance. Immunohistochemistry was performed and the chief cells were immunopositive for synaptophysin and chromogranin A. They stain other neuroendocrine markers as well, that is NSM1, CD56, and these also show patchy pancytokeratin and CAM 5.2 positivity. The sustentacular cells are positive for S100 and SOX10, and occasional GFAP positivity may be noted. Ki67 proliferation index is low, confirming the benign or the indolent nature. Now, these tumors are GATA3 negative as compared to GATA3 positivity found in the extra CNS paragangliomas or the pheochromocytomas. So thus we rendered a diagnosis of Cauda equina neuroendocrine tumor CNS WHO grade 1. So this is histology of the case 2. In this case, we can appreciate the neoplastic cells, cheap cells have clear cytoplasm. This is the vasculature, delicate vasculature. Again, IHC was performed. Cauda equina neuroendocrine tumors are intradural extramedullary, slow-growing, benign neuroendocrine neoplasms arising from the specialized neural crest cells in the region of Cauda equina or phylum terminal. Previously, these were classified as spinal paragangliomas, but because of their unique molecular genetic profile, WHO CNS5 has rendered them Cauda equina neuroendocrine tumor. mRNA analysis revealed that these Cauda equina paragangliomas express homeobox transcription factor 13, which is developmentally expressed in the caudal extent of the spinal cord. These tumors are rare, sporadic, and less than 300 cases have been reported as per the WHO CNS5. These comprise approximately 3% of spinal tumors and about 3.5% of tumors in the Cauda equina or the phylum terminal region. These are frequently misidentified or underdiagnosed preoperatively as schwannomas or ependymomas. Most commonly diagnosed in adults in their 4th to 6th decades with a slight male predominance. Macroscopy, these are well circumscribed, delicately encapsulated oval to sausage shaped red-brown vascular masses that bleed freely, and the size ranges from 10 mm to 112 mm in the greatest dimension. Capsular calcification or cystic change may be noted. Gross appearance may resemble a myxopapillary ependymoma, and if submitted with attached phylum terminal, proximal and distal ends should be sampled for the surgical margins. Clinical findings. These are typically indolent, slow-growing tumors. Clinical findings generally present in two categories: local spinal mass effects and rarely hormone-driven systemic symptoms. The primary clinical symptoms are due to mass effect, that is lower back pain. The most frequent presenting complaint, often described as dull and progressive. Sciatica or radiculopathy is in form of radiating pain, numbness or tingling down one or both the lower extremities. Weakness and paresthesia, motor weakness and altered sensations in the leg or saddle region. Sphincter dysfunction in form of bladder or bowel incontinence and sexual dysfunction. Classic acute Cauda equina syndrome is actually quite rare at the time of initial presentation. Rare systemic symptoms may be due to endocrine activity. So these may be due to some tumors secreting peptides such as somatostatin or serotonin, leading to episodic hypertension, headaches and palpitations. Though most of the Cauda equina neuroendocrine tumors are non-functional. Intracranial hypertension. Very rarely, tumor-related bleeding can cause papilledema or symptoms of raised ICT. Imaging findings. As discussed, these are well circumscribed, sausage-shaped intradural extramedullary masses. While imaging overlaps with other spinal tumors, this tumor has key vascular hallmarks. On T1, these are characteristically hypointense to isointense. On T2, generally isointense to hyperintense, frequently display a salt pepper appearance, where pepper represents dark serpiginous flow voids from high vascularity and salt represents focus of tumor matrix hyperintensity. On T1 contrast, these demonstrate intense homogeneous post-contrast enhancement. For vascular signs, CAP sign should be looked for, that is a peripheral hypointense T2 rim from the subcapsular hemosiderin due to chronic microhemorrhage and distinct serpiginous flow voids capping the tumor boundaries. DNA methylation profile and chromosomal copy number profiles of Cauda equina neuroendocrine tumors are distinct from those in the other locations. Treatment and prognosis. The gold standard treatment is gross total resection and it is the definitive and curative treatment. Due to vascular nature and frequent adherence to the phylum terminal or the nearby nerve roots, meticulous dissection is required. The adjuvant therapy, that is radiation therapy, is rarely indicated and is reserved for cases with subtotal resections where residual tumor cannot be safely detached from the critical nerve roots or in exceptionally rare cases of recurrence. Prognosis is excellent following complete surgical clearance. The long-term recurrence rate is under 5% following gross total resection, and CSF dissemination or malignant transformation is extraordinarily rare. Thank you very much. Please subscribe my channel for more interesting cases. Good day.